All right, kia ora. As I was introduced, my name is Vincent Lomas. I am a doctoral student with the School of Mathematics and Statistics. So, to quickly introduce myself, I born in Auckland, grew up in Tauranga. I am Ngāi Tuahuriri, so this is my sort of rohe. And I came back to study mathematical physics at my undergrad initially. And then I went and did a PhD of mathematics focusing on infectious disease spread with a focus on that health equity side. And that's with Mike Planck and Tim Chambers and now Leighton Watson as well. So the idea of this project is during COVID, there was a distinct lack of models that could answer important questions about ethnic equity and health outcomes. I was going to go over and mention about some of those, but as Sarah did this morning, they are pretty obvious. They are pretty bad with Māori and Pacific people having not only higher incidence rates, but also hospitalizations and mortality rates due to these diseases. And the models that we had just aren't very good at including those heterogeneities such as age and socioeconomic status, but ethnicity as well, in those models and predictions that we use to inform policy. So that's what we wanted to do, is develop a model that explicitly considered those ethnic effects, which would allow us to see what effect policy would have on different ethnic groups, to have a more equitable decision-making process, and adhere to the Te Tiriti guidelines in those things. The focus of this first body of work that I'm presenting now is to better understand the main drivers of transmissions between those ethnic groups. So I'll go over some prior epidemics really briefly in COVID. The model that my work is based on, and then some stuff about the model like proportionate and assortative mixing, the effect of vaccinations, and then quantification of model parameters, although I won't get too much into the maths because I don't think you'd want to hear that. But to start off with prior epidemics, as I've alluded to, in all prior epidemics, since Europeans came, basically, there have been strong ethnic inequities, especially in the 1918 pandemic, where there was Māori hospitalization rates were 7 times more than European counterparts. And more recently, in the 2019 measles outbreak, there was a strong burden of disease on Pacific people as opposed to everyone else. And this has some other effects other than ethnicity, which is why I'm mentioning it here, and then we'll bring it up again later. But to model these diseases, there haven't really been that many, this much work done on it before. But one of the big bodies of work is the Ma et al. Paper, which studied the effect of ethnicity on these models in New York. So what this paper did is it considered 2 major types of parameters, which were contact rates and assortativity constants. Contact rates were saying that different ethnic groups contacted or interacted with a different amount of people per day to spread that disease. And assortativity was just the proportion of contacts that were within ethnic group. Right? That accounts for things such as families, community, cultural events, those sorts of things, because we don't interact with every ethnicity randomly. You can see on the left here we have the incidence trajectories, or just a number of infections that differed by ethnicity. And on the right we have at the top, the homogeneous model, which is the model that does not consider those ethnic effects. And in the bottom, some variations of that model, which shows that these effects do influence things like the final epidemic size. And this is the idea of the model. It's just an SEIR model, which means susceptible, exposed, infectious, and recovered, where there are susceptible individuals, some vaccinated, some not, who get exposed to the disease by infected people. After some incubation period, they become infectious, and eventually they're recovered, at which point we consider them immune. So this is a a compartmental model that splits the population into one of these four groups. And then traditionally, we would split it up by age or maybe deprivation or some other things. But in our case, we split it up by ethnicity, considering the four major ethnic groups identified in health and census data in New Zealand: Māori, Pacific people, Asians, and then Europeans and others. This changes the model a bit, but that's not really the interesting part. The interesting part is what we apply it to, which in this case, we're focusing on COVID-19. And we picked this for a few reasons, but it had early predicted disparity that materialized later in the pandemic. There were recommendations for prioritizations of vaccinations or of other health programs that were pretty much ignored, or they weren't prioritized enough. And it was useful for my models, particularly because there's a lot of data about it, and it's not dominated by other effects such as existing immunities from the disease already being around, because this is trying to model pandemic scenarios. Data set, we used the publicly available one that just looked at aggregated counts. We got this from Te Whatu Ora. It was the confirmed case data set, which has a couple issues in it. You can see that the Pacific people's plot has a spike. It's very sharp on the left side, and that could be for a couple reasons, which is Pacific people live in closer together spatially, so that if one Pacific person gets sick, a whole bunch more would. But it could also be because testing wasn't widely available at this time. And so to account for this, we're looking at the total confirmed cases per ethnicity, instead of some measures like the shape of the curves. And from this, we can start to fit the most basic version of this model, which just looks at group-specific transmission rates. And that's what that looks like, with Māori and Pacific people having clearly higher transmission rates than other ethnic groups. I thought I'd stop here and mention that these transmission rates are not biological differences. They are just aggregations of socioeconomic, cultural effects, age distribution effects, those sorts of things. We're not aiming to imply a causality. We're trying to get a correlation effect to see how these things could affect different ethnicities, or how the different decisions would affect different ethnicities using these correlated effects. But that model is overly simplified because it kind of just assumes that people interact with everyone randomly just based off of that one contact rate. So we needed to include some sort of spatial effects, and for that we've used some census data from Te Whatu Ora again, and from StatsNZ, focusing on statistical areas. We focused on them because they aim to reflect communities that interacted together socially and economically, which can give you a good idea of sort of disease transfer within these groups. And within these statistical areas, we assumed that people did meet randomly. So this kind of means that within a neighborhood, you'd meet everyone in your neighborhood as likely as anyone else. It can give more of an idea of that within household infections, which with a bulk of COVID infections. It can be a bit limiting, but one of the main issues in this study was just the lack of availability of data during COVID, like serio surveys, which we were not done, but were done in the New York study, which allowed them more insight than we could get. And from this, here's a bit of maths. There's the proportionate mixing, which says people meet randomly. On the very right side, the non-parametric mixing is that spatial pattern that the model tries to estimate. And in the middle is the assortativity model, which is the inclusion of that preferential interaction within your own ethnic groups. You don't need to look at the specific numbers. just know that B is what we're mainly working with, and prior models have just assumed that these values were the same for everyone. There was nothing there. From this, we could do some quantification analysis. So we basically wanted to see in our model what was the most important part, what was the most important parameter that we were considering, I should say. On the left, on scenario 1, is the base scenario, which has this simplest model, everything's included, or not simplest model, the most complex model, everything's included. And there are vaccines, there's that assortativity I showed you, and there's that transmission rate differences. Then we said, what happens, what changes to the total number of infected people if we just remove the assortativity? So remove that preferential interaction within ethnic groups, and it doesn't really significantly change the final infection rate for different ethnic groups. As you can see, between 1 and 2, the bar graphs look pretty similar. And it looks pretty similar to number 3 as well, which is saying if we average the vaccination rates and remove that vaccination disparity, what happens to the number of infected people? Which, as you can see, does not significantly change it compared to the 4th scenario, which is when we average those transmission rates. And these transmission rates, or this shows that these transmission rates are the most important part of our model, as opposed to vaccination rates and assortativity. And from this, we can say things like disparity in the incidence rate from COVID-19 was not caused by, or vaccination rates are not adequate to explain that disparity alone. And we need inclusion of other effects, such as those transmission rates in the model. Now, there are quite a few limitations in this, which transmission rates can't explain all the disparity alone, but like I said, neither can vaccinations or some of the other effects that have been considered in the past. It's a combination of those effects. The proportionate mixing within statistical areas was a big simplifying assumption that we needed to make due to the lack of availability of data. But if more data is collected, we can refine the models. One big thing is that, like I said, transmission rates tell us correlation, not causation. So we're not actually finding out the drivers of these inequities directly from this model, but it just gives us an idea of some changes and how changes would, in pandemic response, could change the number of infected people. As part of that, we have not considered hospitalizations or deaths in this model at all, but we do in future work. I've kind of ignored it, but we assumed that for every case that was reported, there were actually 2 cases present due to the bulk of cases coming from self-reported data, which is not very reliable, which again is why those serial surveys and other data collection methods are more important. And the biggest point is that it's not very easy to verify transmission rates. Right? There have been studies done in Europe, such as a polymod study, which have estimated transmission rates within those European countries and found that they're not super sensitive to country, but they don't care about ethnicity at all. All of the other models, or most of the other models before us, have considered only those age effects and not ethnicity effects. So a lot of the existing literature only can explain those age differences or give us information about those age-based differences. As part of that, in our next steps, we are adding age stratification to kind of separate out those age effects from those ethnic effects that we're considering. And age effects are included for a good reason, because there's strong age dependence on disease spread, such as in the 2019 measles epidemic, children were way more affected than adults were due to less vaccination in those groups, which meant the disease could spread more through them and cause a lot worse health outcomes for those age groups. We're also looking at some other pandemics and then looking at IDI data to analyze better data than the publicly available ones. And then I'd just like to acknowledge my funders and my supervisors. Thank you.